Good morning, ladies and gentlemen. Welcome back to Voice International Conference 2018. Very lovely to see you all here. This is the final day of our conference. It's been a productive 3 days, 2 days, today is the third and final day, of exciting discussions, workshops, and special sessions where we exchange ideas, insights, and experience. It's been very delightful to see everyone here having such passion and dream to better child protection and well-being wherever we are. We're very happy to welcome among us Ibu Suharti, Head of Planning and International Cooperation Bureau at the Ministry of Education and Culture Indonesia. Welcome, Ibu Suharti. Good morning to our host, Ibu Santi from PUSKAPA and Pak Mark from CPC Learning Network. To start our morning, we're going to listen to Bapak Ahmed Mushtaque Chowdhury, Chairperson of BRAC from Bangladesh. Bapak Ahmed is going to deliver his keynote titled Turning Evidence into Meaningful Action and to Start Now. Bapak Ahmed, the stage is yours.
The voice co-coordinators, Santi, as Mark was saying, the Queen Bee, and of course Mark, my friend and ever smiling colleague from Colombia. Ladies and gentlemen, excellencies, it's a real great pleasure to be here today to come to the conference, the Voice Conference. And it has been a wonderful 3 days that I was here. And I'm really delighted that I was invited to this very important conference. I have been to Indonesia a number of times. This is my second time to Bali. There are so many similarities that I see between Indonesia and Bangladesh. And we have had a lot to learn from Indonesia. I remember it was in the 90s that my boss, the founder of BRAC, Sir Fazli Hassan Ahmed, and I came here in the 90s to learn more about the family planning program here. At that time, BRAC was seriously thinking of doing something more on family planning, although Bangladesh was doing well. But we thought that it's important that we really work harder in order to achieve more in family planning. But we knew that Indonesia has done very well in family planning. It was in the late 70s and 80s that Indonesia made a huge kind of progress in increasing family planning acceptance in this country. We know of the many innovation that you did in order to promote family planning in Indonesia. One of the things that I remember I was told by the famous person, Professor Suento. Professor Haryono, I'm sorry. Haryono. That Indonesia is a Muslim country, so it's very important that we sort of connect family planning with what the Quran says. And Indonesia brought Muslim scholars from Al-Azhar University in Egypt in order to find out what the Quran is saying about family planning. And they introduced those kind of teachings into the family planning programs here. And we thought that this is something that Bangladesh should do. And we actually followed Indonesia. And did a lot of changes in our family planning program in Bangladesh. And I'm very happy to tell you that Bangladesh has done quite well in family planning. The contraceptive prevalence rate has now gone up to over 60%. So we are so grateful to our friends in Indonesia for showing paths to many. And day before yesterday, we are I think it was yesterday we were hearing about the progress that you have made in universal health coverage. You have already covered 200 million people in this country through the UHC. But Bangladesh is still struggling to really introduce even, we don't even have 5% under the universal health coverage. So we have a lot to learn from what you have achieved. There are other similarities as well. We see that we are told about the stunting, and we have a very similar stunting rate in Bangladesh. It's over 30%. So we have a lot to work together. And so for all these reasons and many others, of course, I'm very pleased to be here in Indonesia and spend time with you, learn what you are doing. Coming back to my presentation, I was sort of asked to talk about some of the things that we have been doing in BRAC. And to start with, many people here ask me always, what is BRAC? What BRAC stands for? BRAC doesn't stand for anything now. It stands for itself. But in the past, BRAC used to stand for Bangladesh Rural Advancement Committee. But over time, we have moved away from rural. We are also working in the urban. And BRAC is not only in Bangladesh, but also working internationally. So there is no point in keeping the old thing, Bangladesh Rural Advancement Committee. So we are only BRAC. So what I'm going to sort of tell a short story on some of the things that BRAC has done, and particularly, which is related to the conference also, how do you use evidence in order to improve the implementation of what you want to do, the improvement of the delivery of programs, and that's exactly what I plan to do today. So the outline is that I will start obviously with a short introduction on Bangladesh, and the same on BRAC. And to talk about a little bit about the evidence generation work that we do at BRAC, and come to the real story that I want to share with you. Is about how evidence improves program implementation and outcomes. And in this, I'm going to talk about the ORT story, the oral rehydration therapy program that we did in Bangladesh some time ago. Now, about Bangladesh, Bangladesh is a country, is a new country in a way, and it was, we became independent in 1971. We have a population which is about half of Indonesia, but it's a small country in terms of the land area. So Bangladesh is the most densely populated country in the world, except a few city-based countries such as Singapore. So that shows some of the challenges that we have, of course. When Bangladesh became independent in 1971, Bangladesh was the second poorest country in the world, after Upper Volta, which has now become Burkina Faso. But over the years, we have come out of that. And recently, we have birthed into a developing country status from the least developed countries. So which means that our income has increased, the GNI has increased, and we have been maintaining a constant growth rate of more than 6% over the last 6 years, over the last 20 years. Also that in the 80s, Bangladesh, the poverty rate in Bangladesh was 60%. But now it has been reduced to 25% or less than that, which also means that about 40 million people in Bangladesh are still poor by any standard. Bangladesh has made good progress in some of the social development things. And the Lancet, you know about the Lancet. So the Lancet did a series on Bangladesh about a few years ago. And the editors of the Lancet, when they wrote an editorial on for the series, they said that Bangladesh is one of the mysteries of global health. The reason is that Bangladesh still is a poor country. There are a lot of inequities. We heard about inequities in Indonesia also. But then still, Bangladesh has made good progress in some of the social development indicators. In education, more than 95% of our children are going to school. Also in health, the infant mortality rate over the years has gone down from 150 to about 30 now. The maternal mortality also, it was about 600, now it is less than 200. With respect to life expectancy, when Bangladesh became independent, it was about 45%, about 45 years. But now it has gone up to over 70. And more importantly, the gender dimension of life expectancy. Until the 80s, Bangladesh was one of the 3 countries in the world where women lived a shorter life. But that's against the norm, against the biological norm. Everywhere women live longer. So over the years, last 30 years or so, this has been corrected. Now the Bangladeshi women live 2 years more than men, which is the normal sort of thing. And Bangladesh is a country which is at the forefront of climate change, like Indonesia and the Philippines and so on. Obviously the life there is built much around what the climate does to us. But still, Bangladesh has an unfinished agenda. As I said, that about 40 million people in our country are poor. The maternal mortality, I say that is less than 200, which is probably better in comparison to some of our neighbors. But it's much above than some of the other neighbors. For example, Sri Lanka. Sri Lanka has a maternal mortality of 30. So that our target is Sri Lanka now. We have to really reach the level that Sri Lanka has reached. The other issues that we are facing with is the NCD, of course, but then also in terms of, since this is a conference on children, we have been hearing a lot about early marriage, and in Bangladesh, the average age at marriage of girls is 18, which means that half of the girls are married off before they're 18, which is the legal age at marriage. And Bangladesh is probably one of the highest, has the highest child marriage rate in South Asia and also around the world, I suppose. So that's a major issue, although we have done so much well in many other indicators, but we haven't been able to do much in increasing the age at marriage. Perhaps because this is related to so many other issues, the issues of security, the issues of the way that we look at our girls, the gender issues, and so on. And Bangladesh is a home to many of the so-called successful NGOs. You must have already heard about, well, already know about Grameen, which won the Nobel Prize in 2006. And there are other NGOs such as BRAC, and I'll be talking more about BRAC today. So coming to BRAC, BRAC is an NGO, as I said, and it was established in Bangladesh in 1972, just after the country became independent. And the purpose was to help the 10 million refugees who went to India during the war. They were coming back, and the founders of BRAC wanted to help those refugees settle in their country, and that's how BRAC was born. But as it happens with any other NGOs, that we felt very quickly that relief is only a short-term measure. People need development, people need healthcare, people need education, people need income and employment, and also the society needs their women to be empowered. So that's how we have been working since 1972. BRAC is said to be the largest NGO in the world. And it depends of obviously how we defined the largeness. So at least in terms of these two criteria, the number of staff we have, number of full-time staff, paid staff, it is the largest. It's about 100,000. And also how many people you reach. So through BRAC, we reach about 120 million people. But certainly we are not, thank you. But certainly we are not largest in terms of budget. I mean, World Vision is much bigger than their budget is over 3 times ours. BRAC, the goal of BRAC is poverty alleviation. But the way that we look at poverty is not about just a shortage of income or lack of income or employment. We feel that people are poor because they don't have access to good health care. They don't have access to good education. People are poor because their women are not empowered and so on. So in order to address poverty, you have to address all the causes of poverty. So that's why we have programs in education, health, particularly looking at the ultra-poor and microfinance. And we believe in scale. So whatever we do, we want to do as big as possible so that we benefit as many people as possible. So in our education program, we run about 40,000 primary schools, which enrolls about 1 million children. In healthcare, we work with the government in the TB program and reach almost 80% of the country. And Bangladesh is a country where is quite unique in the sense that that a national program has been handed over to NGOs to implement, and that's the TB DOTS program. And the country is doing very well in combating TB. Also, with respect to microfinance, BRAC is one of the 3 largest players in this. We have over 6 million borrowers through which we provide microfinance. Indonesia has also large microfinance operators. And BRAC is also involved in humanitarian work. And BRAC was started as a humanitarian organization. But recently, as you know, that Bangladesh has been going through the Rohingya crisis, which has been imposed on us. But we have welcomed the refugees, and BRAC has been one of the first to respond to this. And we have large programs in the Rohingya camps. There are about over the last 1 year or so, about close to 1 million Rohingyas moved to Bangladesh and now residing in many of the camps that has been set up. And BRAC has set up in the initial phase about 18,000 latrines, for example, about 10,000 hand pumps for drinking water. The other things that we are doing is to really create safe space for children, and through that we have close to 250 centers that we have established, where we are providing safe space for the children. We are also trying to sort of do case management and also doing psychosocial support. And these 250 sort of centers are enrolling over 50,000 children. So this is an important work that we are doing with respect to the serving the cause of child protection. And we are also experimenting with newer things such as how do we establish play labs in a humanitarian situation. And we are working with the Lego Foundation in developing a model of how do you sort of organize play labs at the refugee camps. And most of our work are targeted to children and women, whether it is the health program or the education program. These are all targeted to children and women. And Bangladesh is a signatory to the SDG, and BRAC also has huge commitment to the SDG, and we believe that we should leave no one behind. Carrying on with the BRAC, BRAC is less known than many other NGOs. And one of the reasons is that we want to sort of keep ourselves low profile. There has been, recently there has been a lot of number of stories on BRAC. And one of the stories which was published in the Economist, the journalist was saying that BRAC is one of the world's most kept secret, because not many people know about BRAC. BRAC believes in sustainability. In Bangladesh, we are 80% self-sufficient. We have many enterprises which sort of generates income for us, and so on. And BRAC is no more only in Bangladesh. We work in 11 other countries, as you can see here, the pink dots. We also work in, we have many colleagues here from Uganda, and I met them here. I'm very pleased to meet them. And in Uganda, for example, just as an example, BRAC has a large operation. The microfinance program covers more than 200,000 households. We also have what we call the adolescent clubs. There are about 1,500 of them. And we also have about 4,000 community health workers. So we have a large operation in Uganda and many other countries, as it is available in the map here. But we also have offices in some other countries where we don't implement programs, but we use those offices in order to serve our purpose. For example, we have affiliates in UK and USA, and the main purpose for them is to do PR for us and also to help fundraise. BRAC is an evidence-based organization. We believe in evidence, and our work is sort of centered on the evidence that we get from our own work and from the work of others as well. And that's why the monitoring and evaluation is an integral part of what we do in BRAC. So most of the evaluation work is done by a independent unit within BRAC called RED, the Research and Evaluation Division. It is quite large, and it has a multidisciplinary team, and uses all kinds of research methods, quantitative, qualitative, mixed method, the RCTs, and so on and so forth. And we work with many universities in the south as well as in the north. And obviously, since our main purpose is to help program improve their delivery, so this division works very closely with them. And obviously, it contributes to the improved implementation of BRAC programs. And in 2001, BRAC set up a university, and gradually the work of RED will be sort of transferred into the three postgraduate institute that we have set up. One for governance and development, one for public health, the other one is for education. Now, coming to the story that I wanted to tell you about implementation and how research can help implementation. I want to tell you back to the 1980s. And that was the time when diarrhea was a major killer of children. And we know that ORT was discovered in Bangladesh in the 60s, but ORT was not available to any people outside the four walls of the hospitals. There were issues of cost, logistics, the illiteracy of the population, and so on. So BRAC thought that we should make ORT, the knowledge about ORT available to every mother in Bangladesh. And they started a program through which BRAC workers went from house to house to teach mothers about how to prepare a homemade solution. Excuse me. So the formula that we developed was that if you add a pinch of salt into 2 scoops of sugar into half liter of water, you get a solution which is very close to what the WHO recommends. So with that finding, with that discovery, we thought that we should let every mother in Bangladesh know about it. And we started implementing that. At that time, WHO was deadly against this. They thought that this is going to do more harm than good because mothers will not be able to prepare the solution and so on. But despite that, we moved ahead and we covered the program, and we'll see what we have achieved. So BRAC, through this program, taught 14 million mothers in Bangladesh, face-to-face, one-to-one. And we introduced many innovative work in the program, which was one of them was incentive salary. So after the health worker has taught a mother, another group of monitors went to the household and see how much the mother has remembered about ORT, and also asked the mother to prepare a solution for her. And the monitor brought a sample of that and then tested it in the lab to see whether the solution has the correct amount of salt and sugar in it. And based on that, the salary of the worker was decided. So that was a very sort of powerful thing which motivated the workers to work harder and better. And the other thing that we had was there were these evaluations, which was an integral part of the program for mid-course, for mid-course corrections. And this shows the formula that I was talking about. The sugar, the salt into water gives ORS. And this shows pictorially that a pinch of salt and 2 scoops of sugar, when you mix into half liter, you get a ORS. And BRAC trained thousands of women workers to go from house to house. As you can see, some of them are walking through the rice fields to go to the village. Here, a woman worker is teaching a mother about diarrhea, what causes diarrhea, and how one can prevent it, and if they have it, if the children have it, how to make oral dehydration solution. This is the worker showing how to measure the sugar, also how to measure the salt, and how to measure half a liter of water, and how to stir it well so that it was initially done on a one-to-one, and then afterwards it was done in a group so that more people are involved in this, can get benefit. So here a mother is feeding the ORS to a child. Now, what is the outcome of that intensive work that we did over 10 years in the 80s? Bangladesh now has the highest use rate of ORT globally. The health and demographic surveys, which is done in over 70 countries. And one of the things that they collect is when their children have diarrhea, what sort of treatment they do. And the ORT rate, use of ORT rate is found from that particular question. And Bangladesh has the highest use rate of ORT, over 80%. And globally, it is less than 60%. I don't remember how much it is in Indonesia, but I'm sure it will be quite high. So what contribution this evidence generation has had on this particular outcome. Turning evidence into action. So I will sort of tell you a few examples of how research has contributed to continued improvement of the program. I said that when we started the program, it was 1+2 in the sense that one pinch of salt and 2 scoops of sugar. But in some areas, we are finding that the salt level was very high. So this sort of it was quite a sort of alarming situation in the sense that we know that if the child is given too much of salt, it can actually lead to death. So we are very concerned about that. What's going on? And we did some research, and we found that in that particular area, the health workers were not teaching well. And so that some of the mothers were doing it the other way around. So instead of one a pinch of salt and 2 scoops of sugar, they were doing it the other way around. 2 pinch of salt and 1 scoop of sugar, which raised the amount of salt in the solution. So we did some research on that, how to do about that. And we found that if you use 1 fistful of sugar instead of 2 scoops, then you get about the same sort of amount of sugar in the solution. So we moved from 1+2 to 1+1 so that people don't have any confusion anymore. And there was no confusion afterwards. When BRAC was implementing that program, there were a lot of talk about whether we should move from a glucose-based solution to a rice-based solution. And there are a lot of evidence coming that rice-based is much better than glucose-based because it reduces the duration of diarrhea and also that the severity of diarrhea. So we did a study to find out what it means for a common mother in Bangladesh. And we found that although it does reduce the duration, it does reduce the severity, but the mothers were not ready to do it themselves because it's too cumbersome to prepare a rice-based solution. You have to grind the rice, which is very hard. You have to sort of boil it and then make it into paste. And then also you have to cool it and then provide it to the child. So at dead of night, for example, the mother won't do it anyway. So we thought that that's although it looks good, but it's not the best solution. So and there was a big conference on this, which was organized by UNICEF and WHO at the Aga Khan University in Karachi, and we presented the results there. The purpose of that conference was to switch from glucose-based to rice-based. So seeing these results, the conference decided not to do that. So the research that we did had also much sort of global impact. In ORT with dirty water, can you, because when the BRAC workers came to a mother, they said that make the solution using safe water, and safe water at that time was the tubewell water or the hand pumps. But hand pumps were not available at that time to every household. So many of the mothers we found were not using the solution because they don't have a safe water in their house. So what to do about that? So we wrote to Richard Feacham, who was the dean at the London School of Hygiene and Tropical Medicine at the time and an expert on ORT. And he said that that's not a problem because any solution, any water, any fluid is better than no fluid. So even dirty water is better than no water. So whatever water you have, you use that. So we changed our message from that instead of asking the mother to add safe water, we asked the mother to add drinking water, whatever water the household was using. We also found that many of the workers themselves were not very convinced about the effectiveness and efficacy of ORT. So if the teacher is not confirmed, is not convinced, then how can she teach others? So we brought the BRAC workers in groups to Dhaka, to the International Center for Diarrheal Disease Research, to show them how the ORT worked. And they saw for themselves how it worked, and they were convinced and went back, and their trust on ORT increased. When BRAC started the program, we did some studies on what proportion of the diarrhea cases are being given the ORT. Because even if the mother knows about it, unless they apply it, unless they to the children, there will be no impact. So we found to our dismay, to our great frustration, that less than 10% of the mothers were using it, although they knew how to prepare it correctly. So there was a huge no-do gap there. And we started looking at the reasons for that. There were a large number of studies done using mostly the qualitative methods. And we found a number of issues there in the program itself. One is that the program was women-centric, in the sense that the health workers were women, and they were teaching the mothers. But in a society like Bangladesh, the men are very important. They are the decision makers, because Bangladesh is a male-dominated society. So even if the mother is convinced about it, she will not dare to use it unless her husband or father or brother says that you do it. But since BRAC was not reaching the male, they were confused about this. Some were even suspicious of what BRAC is doing. So we changed the entire methodology, and we recruited hundreds of male workers who went from village to village, talking to the male in the mosque, in the bazaars, and in the schools. So that increased the water usage to significantly. Then we also found that the village doctors, they were not supporting this program. The reason was that this was related to their livelihood, because they used to provide the intravenous injection when there was a diarrhea. So this was a kind of a way that their income was being reduced. So they are not supporting this. And we found it quite difficult to convince them that you should, because it was related to their livelihood. So what we did was that we told the village doctors that we don't want you to say publicly that this is better than anything else, but at least you don't oppose this. So you do whatever you are doing, but at the same time don't say that the ORT is not good for children. And finally, one of the reasons we found was really related to the cultural perception of diarrhea. And we found that although to every one of you, to the doctor, that any fluid coming out of the body is diarrhea. But to the villager, there were 4 types of diarrhea that we found. And according to the mothers, each of these type had different etiology, had different causes, and each of them had different names. So as I said, that to the doctors, that they are all diarrheas, but to the villagers, they were separate different diseases with different causes. So how this is related to the use of ORT? We found that one of the 4 types was what villagers called diarrhea. And by that, they meant the severe watery cholera-like diarrhea. So we found that they were actually using this solution when they had that type of diarrhea, severe watery cholera-like diarrhea. But if you look at the number of occurrences, the frequency, this fourth type, what the villagers call diarrhea, was only about 10% of the total diarrheas. So even if you have 100% use in that particular category, it's not going to have an effect on your overall rate. So what we did was that we changed the teaching methodology, the message that we are giving. The health workers, instead of saying that when your child has diarrhea, use ORT. They say that when your child has dudhaga, when your child has ojirno, when your child has amasha, or even diarrhea, which is the solution. So one of the things the health workers did first when they entered into a village is to find out what are the local names for different types of diarrhea. And they used those names in order to teach mother that if your child has those kind of diseases, use ORT. And that had a huge impact on the way the mothers looked at ORT and its use. So that was some of the sort of research that we did in order to improve the programs. Now we know that, as I said, that Bangladesh has the highest use rate of ORT. It's over 80%. And it is now saving about 500,000 lives annually. So it has a huge impact. And we know that it has contributed to a drastic drop in the under 5 mortality rate in Bangladesh. When Bangladesh became independent, a quarter of the children died before their 5th birthday. Now the under 5 mortality has reduced to about 32 now. And that ORT, because of this this decade-long work, the ORT, what we call locally we call them Lobangur solution, is now part of the Bangladeshi culture. So if you go to a village, ask what is the treatment for diarrhea, I'm sure a large number of the people will say ORT. So that was my presentation, and based on what I've been hearing here about the different terminology and I can sort of suggest this conclusion to address the 21st century challenges for families, communities, and public policy, development of viable and operable ideas and their effective implementation. I repeat, effective implementation through the use of scientific evidence is a call to action. Thank you.